Yes. Okay. So we're going to flash through a bunch of the slides just because I really want to get into how do we take CARS from an assessment standpoint and have that guide our treatment intervention as well as assessment. But I do want to kind of touch on some stuff because I'd like to give you guys a taste of how we use CARS in FRC, and like the webinar that you guys all just got is like an extension of FRC CARS. So if I can give you some more information on it, it's going to make that webinar just a little bit more valuable. So just to put CARS stands for Controlled Articular Rotation. So it's big joint circles at the outer ranges of articular motion. Okay, so just to kind of put a definition on it, right here. So active rotational movements at the outer limits of motion. Okay, so to kind of start this, Dre has this, the evolutionary perspective of health. So before we get into CARS from an assessment standpoint, we teach everybody something called the morning routine, which is a really low effort level rotational joint movement to kind of warm up and prepare for your day. And we do this to supplement for the fact that we don't move the way that we are naturally intended to move anymore. We've left the food chain, and normal living does not require us to really act like a human anymore. Everyone understands that, right? Like that's why we have exercise, that's why we have treatment, things and so forth. So Dre has this thing called his evolutionary perspective of health, and we have a few questions to answer. So the first one is, what are we naturally selected to do? What are we currently doing? And then on a daily basis, how are we compensating for the fact that we don't move the way that we are naturally intended to move? So we were naturally, everyone understands that we're naturally meant to hunt and gather. So we're moving, and there's studies to show that like hunter-gatherers move upwards of like 700 times the amount that we currently move right now, which is like a disgusting amount. But essentially, like they're moving
7 to 15 kilometers of walking.
Yeah, they're moving, not like they're doing high intensity interval training all day, but they're doing some form of movement from the moment that they wake up to the moment that they go to bed. Does that make sense? Okay, so and right now, because we don't move as much and we move in such small ranges of motion, like we talked about the person kind of painting the story of the office worker that wakes up after sleeping 6 to 8 hours, they sit in a chair, and then they go sit in their car, they drive to their office, they sit in the chair again, so their hips are never seen past 90, knees are never seen past 90 degrees of flexion. And then when we ask them to utilize a more global range of motion or something outside of that range of motion, we're surprised that they don't have it. Okay, so CARS are essentially on a daily basis how we can supplement for the fact that we don't move the way that we are naturally intended to move. So that morning routine I'll kind of show where that sits on our CARS continuum. That's what we use to supplement on a daily basis from a joint health perspective. So every day you're going to wake up and you're going to move every single one of your joints through its full range of motion at a very light intensity, just to stimulate some movement and keep the range of motion that you currently have. Imagine you have someone that's like a baby and you constantly move their joints. They get to like an age where they're either in martial arts or like I have a kids ninja class, and I teach them how to do CARS. So the kids that already have their prerequisites, they already have normal joint function, we just teach them how to move within their range of motion on a daily basis. They should never lose that range of motion. Does that make sense? Mm-hmm. Assuming that like they don't get injured and things like that. Okay, so that's how we compensate for it. There's a lot of uses for CARS from range of motion maintenance that I just talked about, and I'll explain about how after we do soft tissue intervention or any sort of treatment, how we can use CARS to, on a daily basis, then back up the newly acquired range of motion that we've created for the client. Articular health and longevity. The only way that a joint can maintain its health is with movement. Make sense? If you don't move it, you lose it. So on a daily basis, we're going to make sure that you maintain the health of your joint, not within normal ranges of motion, but within the normal range of motion for each individual articulation. Does that make sense? And the reason, and this kind of gets brought up to people who go, well, I use full range of motion exercises. And you ask them to show you what they do from an exercise standpoint, and you find out that they don't use the articulation in all of its ranges of motion to maintain the health. So maybe they do a lot of overhead work, or they do exercises within this plane. But I don't know how many people I've seen come into me for treatment from somebody that reached into the backseat of their car to grab like a purse, and they injured their shoulder, or they threw out their back or something like that, because their glenohumeral joint never goes back into extension, actually does training from that spot. Mm-hmm. And then they go reach back there cold, and we're kind of we're surprised that they get injured back there. Okay, but they've never done anything to maintain the health of their shoulder within this position. So something like a car might look something like this for a shoulder, where I'm going to take all the actions of my shoulder and I'm going to put it through as large of a range of motion that I can comfortably take my shoulder into. I'm not cranking into a range of motion. I'm taking the range of motion that I comfortably have and I'm trying to utilize it on a daily basis to maintain it and make sure that my joint is essentially smart at all of those ranges of motion. Make sense? Yeah? Okay. And then articular screening, that's what we're really going to be talking about. We'll go into that. And then as far as from a rehabilitative standpoint. So range of motion standpoint, essentially from providing signal for tissue remodeling. So as tissue's being laid down, remember if somebody's that office work that's always sitting in a chair and their shoulders are always rounded forward, connective tissue is going to start to be laid down to solidify those ranges of motion. So you have, like Mike and I were talking about too, if you have somebody that has neurological tightness because they never see a range of motion, likely they're going to have mechanical tissue tension as well. So you're not just going to have mechanical tension or neurological tightness. A lot of times you're going to see both of them combined. So they're going to have neurological tightness because those spindles are set to be stuck in the range of motion that they're currently always in, but then the connective tissue continuum is going to reinforce that as well, because that's what their bodies are seeing on a daily basis. Everybody understand that? Okay? Articular health and longevity, it's kind of what I was just talking about, that the only way that a joint can maintain health is with movement. So on a daily basis, we want to constantly move that joint, get all old synovial fluid out, stimulate new synovial fluid production, as well as create blood flow to the joint, maintain mechanoreception at all angles of that joint and all of the tissues surrounding the joint. And then we also know that the deeper that we go into the joint, the less blood flow that there is to those structures. So that the only way that those tissues can get nutrients is with movement through diffusion. So as we're moving our joints, actually, this is something I've been doing too on a little side note. A lot of, and I stole this from Dewey, but a lot more aerobic activity. So you get kind of blood circulating throughout the entire body would be a perfect time to then program articular work. Because now that we have blood flow stimulated through the body, then we do articular training. So we're getting the joint to actually move. So through diffusion, we're getting that fluid to actually be disposed into the deeper capsule tissues, ligamentous tissues, cartilage tissues, and so forth. So it's kind of a good time from a recovery standpoint to do low-level aerobic work combined with articular training, like carbs. Okay, so that's something I've kind of been doing from a training standpoint for myself. And then articular screening. So this is going to be, let's see, perfect. So we were talking about normal and abnormal joint function kind of before, and like first, when someone's going through a range of motion, we want to look at, this should help guide us to where we start our tissue intervention. So if I'm going through, again, like a glenohumeral car, I'm going to start with external rotation to my maximum capacity, and then I'm going to start to adduct. And then I'm going to start to forward flex, then I'm going to hit that roadblock, and then I'm going to start to internally rotate, extend back, and complete that circle. And then we'll rewind that. As I'm looking at somebody perform this global range of motion task, we're trying to gather information. Okay, so we're seeing, one, what's the quality as well as quantity of their workspace. So if somebody has an injury, their workspace might only be through here. So we know that they have a very poor workspace at the glenohumeral joint level, okay? But if they're going through here, we're also looking to see, is there normal, abnormal joint function? And we define that with, is there closed angle pain or opening angle pain? Okay, and that really helps guide us to where we're gonna actually start to go through and assess, because normal joint function, even though it might be limited in range of motion, is going to be, the tissue that's limiting it is going to be the progressive angle. So if I'm raising my arm up to flexion, if this tissue limits me, but I'm still stuck and I'm not in full flexion or as much flexion as I would like, that's still normal joint function, it's just limited range of motion. But if somebody's raising up overhead and they hit a roadblock, or I see a pain face, and I say, well, what's stopping you? And they go, it's not this, I feel like a pinch sensation on the posterior aspect of the shoulder. So then I say, okay, well now I don't care as much about this, I care more so about what's happening at the joint level because that joint is not responding correctly. Because the rate limiting factor to range of motion should always be the progressive angle and not the regressive angle. Does that make sense? Okay? And that usually we talk about this, like get some tasty notes from about what's causing pain. Is it a closing angle pain, like sharp, or is it a closing angle restriction? Because they are different. Sometimes people maybe just don't know how to utilize the regressive flow of tissue to pull them into a range of motion, and it's pretty easy. But if they have like a sharp pain, like what a lot of people are going to be dealing with, like they have sharp closing angle pain, and we don't necessarily care about this progressive angle. We're going and seeing like what's causing that closing angle pain, and usually then we know that it's directing us straight to capsule tissue. Okay, so and I'll give a few examples of this that I just had with a client that came to the gym. So a client came to the gym and I was looking at her cars, and what I saw, she went to here, and then she would hit a roadblock about that much flexion, and then she would start to, and no injury, and then she'd start to internally rotate, nothing, she would carry her scapula like this, and she had a little bit of closed angle pains, because I asked her what stopped her, and it wasn't the progressive angle. She was saying, stuff back here, I can't stop, it kind of pinches. So all I gave her is I assessed internal rotation, so I pretty much looked at the posterior capsule. So if a normal joint function, if you have, so one bone, another bone, and then the two bones that come together, you have the joint. So if they should theoretically move independently without ever touching. If I have posterior capsule fibrosis or restriction, and then as they're opening the joint, it's going to catch on that posterior aspect, and you're going to get closing angle pain or pinching on the anterior aspect. So if I'm raising up here and I get pinching on the anterior aspect, a lot of times the posterior capsule is fibrotic. So for this client that I was just working with, she had limitation with flexion, internal rotation through cars, and some closing angle pain. So I didn't care about assessing tissues in the flexion at that moment. I looked right at internal rotation. She had very, very limited internal rotation. So all I gave her was pails and rails for internal rotation to open up the posterior capsule, and a month later, all ranges of motion increased, not just internal rotation, but because we freed up the capsule, that freed up the ability for the shoulder to go up into flexion. Does that make sense? Because the posterior capsule was what was limiting range of motion and causing closing angle pain. So we started to clear up the posterior capsule, and we started to get more range of motion within all of her shoulder actions with no closing angle pain, without ever training shoulder flexion, abduction, extension, things like that, besides doing cars. Okay, so that's one of the things that kind of helps us prioritize, like you were asking about, like, well, what do I do? I have neurological tightness, we have capsules, we have this stuff. We're taking a lot of information in and having that guide us into our intervention. So if we know that we have closing angle pain, that we're going straight to checking capsule. If they go here and they're like, well, I feel like this stuff is stopping me, and this is the progressive angle, where do you think I'm going to start my tissue intervention or my assessment? Am I going to start back here? Or am I going to start on the progressive angle and seeing what kind of tissues maybe is limiting shoulder flexion? Does that make sense? Are you sure? Okay, because I'll bring a few of you guys up and we'll run through cars and we'll kind of all dissect this together, because that's really important, because that helps you, if you have a half hour or an hour with somebody, it helps you prioritize where you need to start. You look at someone's cars, they have shoulder pain. They have closing angle pain, it directs you straight to go and assessing capsule. So you prioritize your treatment to going directly to what you feel like is contributing to the issue. If they're going, well, I just have some limitation here and it feels kind of sticky when I go back and maybe it feels weak or whatever, then you go check the progressive angles that are limiting them from going into range of motion and see if you can start to expand their available workspace. Okay? Does that make sense? Okay, so again, just to show you guys one more time the actions of a glenohumeral joint, and then I'll kind of show you guys some of the common compensations that we'll see, and then you guys can tell me what's the opening angle, what's the closing angle, as far as like where would I start my tissue intervention, and then we'll have some people come up and we'll actually all assess some glenohumeral cars together. So how we do it is, again, we're just looking at the quantity, so how much external rotation do they have? How much adduction do they have? How much flexion do they have? Internal rotation, extension from a overall workspace perspective. And then from there also, we're trying to see, are they compensating? Is there pain? And then, maybe they have the range of motion, but maybe it looks really sloppy. So we're not just looking at quantity, but we're actually looking at the quality of them to control their glenohumeral throughout their workspace. Make sense? Okay, so for cars.
Question? Yeah, quick question on the cars. So you mentioned starting external rotation adduction.
Mhm.
Do you then do the opposite? Do you do internal rotation adduction?
No, not usually.
Why?
Usu-
Different tissue would be at tension with internal rotation adduction versus external rotation adduction.
It's a closing angle position.
The other thing too is like the thing that I kind of remember with cars too, because people ask that, and there's like where do I start here? Do I start here? Can I? And really, what you're looking at is like what is the glenohumeral joint in this case capable of doing through an active outer limit range of motion standpoint, and then we're going to narrow it in from there. Because maybe you want to go check and see what their pure internal rotation is from a capsular standpoint. Maybe you want to see what their internal rotation is and adduction for their sport, because then you can get more specific. But right now we're just starting general and allowing this to kind of guide us into more specific treatment intervention, okay, or assessment. So we start in external rotation. So I'm trying to see first, before I get into this, the procedure with cars depends upon the what we're trying to do, and with the I guess I should put it up on continue. Oh wait, yeah, that.
Continue where I went.
But so pretty much we're gonna start with that abdominal bracing, or what we call irradiating. So we do that to stabilize all articulations, as well as move through control on the articulation that we're taking through a range of motion. Because what I don't want to see is somebody just sloppy going through a range of motion. I want them to breathe in, trap air in their lower abdominal region, and create some like a bracing effect. And then from there, if I walked up and I just tried to move them, like they should be somewhat stiff everywhere throughout the body. Because what I don't want to see again is everything else come along for the ride. So this helps us point out compensations quite a bit further. So what I'm going to do is create an internal force right now of about 30-40% effort, with the moving joint force being about, or MV, ramping up to my maximum voluntary contraction of just a little under that. Okay, so that way I stabilize everything else, but there's resistance with my moving joint. So we start with external rotation. I'm going to start to adduct. So I'm seeing how much of external rotation adduction I have. I'm going to start to forward flex. Now from here, I'm looking to see, are they rotating through the spine? How much external rotation and adduction they have. When they start to raise up into flexion, are they starting to bend at their elbow to compensate for the fact that they can't reach overhead? Are they starting to extend or rotate through the spine? So we're gathering information. Once we hit that roadblock and I can't go into any more flexion, then I'm going to start to internally rotate. And every millimeter counts. So as I internally rotate, I'm going to extend back, and I'm going to reach back into as much extension as I have, parking my hand into full internal rotation like so. And then we're going to rewind that. So I'm going to go back into extension until I hit a roadblock. Then I'm going to start to externally rotate. I'm going to continue to externally rotate as I bring my arm back up into flexion, start more external rotation as I adduct, and then complete that circle. Now you guys didn't see any compensations because mine is perfect. But we'll bring some up because there's a learning process too. So we'll do this a few times. Like as I teach somebody, like we'll start with one, and maybe it just looks like maybe it looks horrible, and they just need some coaching cues. So I'm going to give them. I'm not just going to be like, nope, you're wrong. Your shoulders break. I'm going to give them some coaching, and then we're going to maybe do it 3, 5, 10 times, as many times as I need to gather the information to where I need to start my treatment. Okay. And then the whole time that we're doing this too, because the topic got brought up about like, what am I doing from an exercise selection? And CrossFitters too are the hardest ones that I have to work with, because they are so emotionally attached to exercise, which is just a made up invention that we created for the fact that we don't move the way that we're normally intended to move. So if you get like so stuck on I can't do a handstand push-up, holy shit. Like if that is more important than having a quality functioning shoulder, I don't know if I can help that person. You know what I mean? Like, cause you gotta get yourself out of pain before you start going back in that. But anyways, so let's say I see someone that can't go into forward flexion, like their humerus can't clear their ear without compensating through their spine, compensating at the elbow, compensating through hiking their scap, rotating the spine, whatever it is. So and that person overhead presses. So they're going to use everything else to shoulder flex because they're going to get the kettlebell, dumbbell overhead regardless, right? But they're going to use other joints to make that action happen. So maybe they're not going to have like an acute injury right away. And that's what people always say, well, my shoulder's fine. Maybe your shoulder's fine, but ask me how your TL junction is in the next like 5 years. Because most of those people start to develop TL junction pain because they're using their TL junction to overextend as they thrust weight overhead. But then what we need to do is just be smarter trainers and therapists and say, you can't overhead press, but you're trying to gain more capacity within your overhead press for weight wise. So you can't go here with your glenohumeral joint, but you can go to here. So if we want to get vertical pressing strength, and maybe they're doing like a military press, I would just get that person to an incline bench press position. So now they can still get their gains with overhead pressing strength, but not having to go into a range of motion that their joint clearly does not have the capacity to go into. Does that make sense? And this goes as simple as like if I'm talking about somebody with a wrist, and because I train people as well, right? And I deal with this all the time, which is why everyone that comes to our gym, we run them through at least a CARS assessment. And that way, it's not like we're trying to steal exercises away, but you kind of present yourself as a better trainer or therapist when you say, okay, so your wrist doesn't have 90 degrees of extension, and you want to do push-ups. Like you have a goal of doing a push-up for whatever reason. So your goal is to do a push-up, but I can't get you into a push-up position because your wrist doesn't have 90 degrees of extension. But we have dumbbells that we can put on the floor, push-up handles, TRX, suspension trainers, we have rings that'll all allow their wrists to stay at neutral, and then they can develop pushing strength from a horizontal position. Does that make sense? So then we just say, hey, just take this specific exercise out, but now we can still build up your capacity in every other way, shape, or form for strength by just tailoring the exercise to the individual. And in the meantime, let's just do some FRC training and FR treatment to your wrist to acquire more extension, so that way eventually you can do a push-up from the floor. Does that make sense? Like that's a way better way of tackling it than just developing wrist arthritis 5 years later, 10 years later, whatever it is. Okay? And again, like this kind of goes for, this is why this stuff kind of starts to bug me a little bit, because then you have somebody that has this much wrist extension, and not only are they doing push-ups, but they're doing handstand push-ups, handstand walks, planches. You guys see what the problem is? And then they're going to destroy their wrist in order to do a made-up exercise. Okay, I'm off my soapbox. I see this all the time. It drives me nuts because I just lost a client who was a CrossFitter, and he hurt his neck. He had closed angle pain. He hurt his neck by doing some backwards roll over his neck that was on the WOD of the day for some reason. And then he was also doing overhead pressing, and he was doing handstand walks because he wants to be like Juju Mufu on YouTube. I kid you not.
You see that? Yeah.
So he had these issues. We got some of the closed angle pain out of his neck, which was pretty awesome in one session that we got some closed angle pain out. His neck felt better. And then I get an email later because it looked like as if I stole his puppy when I told him that, hey man, why don't you just limit overhead exercises until we figure your neck out?
He's not like that.
Huh? Oh, he hated it because he canceled his next session. I haven't seen him since. But it's like, okay, like at that point you can't help someone out anymore because they're so emotionally attached to an exercise that they don't care about the biological damage that they're doing to their tissues.
Can I just bring something up real quick, tying back into this guy's question from earlier? This happens all the time in real practice where you just have to fire a patient or they're going to leave you. It's just not a good fit. If you tell a patient,
100%.
hey, you need to take 2 months off overhead until you get there and they don't come back to see you, that's a good thing. Like, that's a patient you don't want to treat.
And that's, it's one.
Send them to one of your other buddies.
Well, that's one of those things that you guys find too, because I've dealt with this. I'm sure everyone that's in here has dealt with it. But if you, where was I going with that? The client. So I knew everyone knows what this guy was doing. So he I told him he can't do an exercise. I didn't tell him. I just said I would recommend you not doing it if you want a better neck. You know what I mean? Like just don't do handstand push-ups for a while because you don't have your cervical spine is jacked, as well as every other thing up here. So, but what he's gonna do is he's gonna bounce around to every therapist until he gets one that says that he can do the exercise that he's doing. You know what I mean?
Or
Like
hear it enough time from different
Exactly.
folks that he finally is like, okay,
Yeah.
I'm the constant. I should try anything. Like, do send it to your friend, and see if after they've heard it from 5 different therapists, they're finally willing to try something that they didn't want to. I've seen that happen
Yeah,
for sure.
totally. Okay, so I want to get on with actually assessing someone's shoulder up here,
Could
but
you use my shoulder?
yeah, but just to remind you guys, what we're looking for right now is the quality and quantity of the workspace. So what do they have available within their glenohumeral joint? And then from there, we're also trying to pull out other things, like if we see a limitation within a certain range of motion, like flexion. Okay, so there's a limitation there. I don't say, do you feel stretchy? I don't say that. I say, they stop here and they keep going. I say, maybe I see this. I say, try not to extend through the spine. And I say, can you raise your arm into more shoulder flexion? They say, I can't. And I say, what's stopping you from going further? So I let them dictate, because I don't want to put something in their head of like, what I don't want them to please me. I want them to tell me what's going on with their shoulder. So if they say like, I feel just restriction here, like I just, this stuff is tight, you know, it's restricted, it's sticky, whatever they use. Then I just go, okay, I'm going to go lat, I'm going to go to teres, I'm going to go to subscap, I'm going to go to, you know what I mean? Like, it's going to help me guide where I might go and put my hand and start my broad-based tissue assessment. Okay? But if they say, it's really sharp and pinchy back here, then I go, okay, I'm not going to check this stuff anymore. I'm going to go check and see what's happening at that posterior capsule, see if I can free up some space. Does that make sense? So right now, we're going to be asking those questions, and then we're going to see where they're compensating. Because we care about those compensations, because if they can't raise up over the head and they're using their TL junction, that's not shoulder flexion. Huh?
No, I'm just sending subliminal messages. Sorry.
Does that make sense? So we're looking for compensations, pinch points, which is, sorry, what I didn't describe earlier, but that's that closing angle pain. We just call it pinch points because it's easier to explain to a client. And then quality and quantity of their overall glenohumeral workspace. You ready?
Yeah.
Okay, so we're just gonna, you saw me do it, you want me to run you through it again? And you guys, steal my coaching cues too. Like there's some that I've stolen from other people and they obviously work, so we'll use them for a friend here. So,
Which way would you?
which shoulder are we doing? Left. So the other thing, so we always kind of want to position our body to where we can see as much of the anatomy as happening. So maybe I want to get an angle or look here. Maybe we'll get some with her looking to the side, so that way we can get multiple angles, see what's happening with their anatomy. So let's just go ahead and start straightforward. Pause. Go back. Wrong. So start with external rotation.
Okay.
And now start to adduct. Bring that arm across the midline of the body as much as you can.
So we're doing
Yep.
full. Okay.
Now she's going to start to shoulder flex, so keep raising overhead until you feel like you hit a roadblock.
So it's harder to do this.
So freeze. What do you feel like that's stopping you from going further?
From here to here was limited.
This stuff. Okay? So then I'm just kind of thinking, okay, for my broad-based tissue assessment, I'm probably going to go put my hand here and assess what these tissues are doing. Does that make sense? Okay, then keep going. And just when you hit your roadblock, just start to internally rotate and carry out that full circle. Okay, perfect. Freeze though.
Rib cage.
Perfect. So we're getting a little bit of rotation through the thoracic spine. You guys see that? We'll get a side profile for it too. Go ahead and try to internally rotate more as you extend back and park. Then back your hand by your head. Okay? Now, you guys get that? So now we'll go ahead and start to extend back. And she's got pretty darn good extension. Now start to externally rotate. Take that arm overhead like you got a pen in your hand. You're trying to draw out as big of a circle as you can.
So I feel a little bit through there.
Feel what?
Restriction,
Okay, does it feel pinchy? Crampy?
crampy,
Okay.
not pain.
I'll explain that in just a second too. Now keep externally rotating as you adduct. Other external
Oh,
rotation.
sorry.
There you go. And then adduct. The reason why I ask is I feel pinchy or crampy, because regressive tissue doesn't really like to function in a really shortened position, especially if they haven't used it there for a while. So I'm cool with cramping. Like if they go through that, man, it's hard to access that. It feels like it's cramping. We just call that neurological confusion. It means that regressive tissue is dumb at functioning in that range and needs more practice. Does that make sense? A pinch point, you're gonna know if it's pinchy because if they raise up overhead, you're gonna see the pain face like this. Of course, I'm never gonna have somebody perform cars through closing angle pain, and you'll never clear closing angle pain up by pushing through closing angle pain. You will only make it worse. That's super, super important. I'll explain about how I tailor cars for individuals after this too, but does that make sense? So I'm okay with fighting through that closing angle restriction that's cramp feeling, but I'm not necessarily cool with it. Actually, I'm not cool with it at all if it's sharp, pinchy, nervy, burning, whatever we all understand those. When someone says those kinds of symptoms to us, like that's something to have caution with, right?
Because that was how my initial assessment and introduction to FRC was they were just like, I've been having shoulder problems for like 12 years. I had surgery, and I kept having like the impingement at the top of my movements. I'm like, oh, just do more cars because you gotta do cars every day, because that's the thing you say to people. And I was like, well, at what point is it?
Was that at a seminar?
No, this is at like an actual practitioner's
Okay.
office I went to, and they assessed me, and they just told me keep doing it. And
Yeah.
I had to modify it on my own because I feel like I know my anatomy well enough, but also it's like I kept getting.
Yeah.
Maybe you can see when.
Maybe they just kind of misunderstood it. I mean, because here's the overall thing.
Just a little.
If I have someone that has closing angle pain on the shoulder, they're still gonna do cars. But if their workspace is so that's their workspace that they go through, and then they have a pinch point right here. So they go through, and then they have this point of shoulder flexion, whatever that causes closing angle pain. Make sense? So if they go, that causes closing angle pain, ow. I'm not gonna say, okay, so here's what I want you to do. I want you to take your glenohumeral joint. See that closing angle pain? I want you to just ram through it over and over. Right? But I also know that the only way that a joint can maintain health is with movement. So the last thing I'm gonna do is tell them not to move their glenohumeral joint. So what I'm gonna do is I'm gonna teach them how to do cars outside of their pinch point. So what they might do is they start their circle. They go through, it's all clean, all clean, all clean, all clean, all clean. And then they hit where the pinch is. And then they have to trace out a smaller circle. So they either etch out through here and then carry on with the circle. So maybe with the shoulder they get pinch point here, they back out, and then they carry on with the car that's outside of that pinch point. So that way they're still able to maintain mechanoreception at all angles. They're still able to guide the way that tissue is going to start to be laid down on a daily basis. They're still going to maintain or wick away any maybe possible apprehension signs that could be lying around that pinch point, things like that. So we're still training the shoulder, but we're just doing it outside of its dysfunction. So I'll either do that, and sometimes it's like maybe they still get pinched at a particular angle. So I just say take your whole circle and just make that whole workspace smaller, so it's outside of the pinch point. So maybe they can't etch it out and do a smaller circle or bypass that pinch point, but they can do this at a much smaller range. I'm still providing the glenohumeral joint with constant movement on a daily basis, but we're not going through the closing angle restriction. But in the meantime, we want to understand what's causing that, and we want to work on treating or training through that. So maybe if it's like a posterior capsule issue, like it's very limited and that's causing budding on the opposite end, then I'm going to work on giving them some drills to open up shoulder internal rotation. And then they're going to constantly use the newly acquired range with cars. Does that make sense? So I'll do this a lot of times with the neck too. They get to here and they go, oh, actually mine does it on this side, I have a Jits neck. So I go through here and it pinches right there. So I stop shy of the pinch and I etch it out and I carry on. I go over here, I stop outside the pinch and I etch it out. Or there's shy of the pinch, and I come back through. Shy of the pinch, and I come back through. Shy of the pinch. Does that make sense? And a lot of times you actually start to clear up some closing angle pain by doing it. Was that you?
Yeah.
But I wouldn't say like, hey, like I'm not doing anything else, just do cars. Because that's not gonna. You're right. It's not gonna clear up closed angle pain. Maybe it does, but in most cases, it needs more intervention, right?
Tell us who it was, we'll take the certification.
I've got listen on schoolyard.
It's just an Instagram handle name. It's not like a real name. Let's get a side profile of that. So face the. So I'll let you guys and raise your hand and just start throwing stuff out. Or actually, don't raise your hand. It's not school. Just throw something out. External rotation. And adduct. So bring the arm across the midline. Start to forward flex. Little rotation.
Extension.
Little extension. So pause right there. I didn't see the extension because of my angle, right? So you guys have a better angle to see that. So which is why we want to look at this from multiple angles too. Okay, go ahead.
Full rotation. Upper torso.
Yep. The other thing that I'm looking at is what's the quality of the workspace. So right now I see it's very hard for her to perform that.
Rotating the other way.
You guys see that?
Now.
Or of quality that looks
Yep.
forward, and then it somehow like gets a little better towards
Mhm.
the top.
So she has what we call sticky points, right? And we have other things that we'll do, we do to train
Care
outside.
about the hypermobile elbow in this.
Not for her training her glenohumeral joint. I obviously see that she's not double jointed, by the way. She doesn't have two elbow joints there. She just has more freedom in that motion. But I don't care about seeing that when I'm doing something like going through cars.
So one thing I will say is on this side, just make a fist. Just fist, pull it in your leg. There you go.
So if I was to really do too, I mean, we talk about bracing, like breathe in, trap her in your lower abdominal region, come up, check, make sure that she's irradiating, and then she's going to start to adduct, forward flex, and carry on with it. Hers actually is really not that bad for. Did you do that for C? Okay, so hers is actually pretty good.
Do you guys know why I made her make a fist and push her
Irradiating,
leg in?
yeah.
This is trying to see if I could get cleaner assessment, right? Her trunk's moving all over the place. Is that because she's just sloppy in the motion? Or is that because there's a shoulder problem? So if I can get her to do this and I can clean up some sloppiness through here, I actually get her to move better through here. So it gives me cleaner information about what is actually happening at her shoulder, right? So you could see as soon as I made her, because she was standing like this, just kind of limp, right? I want her to have a little bit of tension on this side. And that cleaned up her thoracic rotation a little bit, right?
Because if you don't teach any radiation, and they're free to go do an uncontrolled articular rotation, you see this a lot of times, right? So we want that bracing effect and just spill that contraction out, which is why we kind of, if you think about I always tell people kind of brace with the midsection as if you're bracing for someone coming up and punching you in the
Punch you in
gut.
the stomach, yeah.
And then as soon as they, because if they just squeeze their left hand, there might still be not irradiating tension through their midsection, so you might still see this. If I say brace, try to grip the floor with your feet, check for tension. Now that they're strong here, usually that helps kind of spill that tension out throughout the body at that point. Okay? Let's do one more rep and then we'll. But you guys kind of see, so as we externally rotate, we go here, she starts to raise up into.
Now what happened? So you guys can't probably see this, but we cleaned up her thoracic spine a little bit. But what happened to her ability to get across?
She didn't go as far as that.
She didn't go as far as cross. Is that better for me from an assessment perspective to see that? Yeah. So that's not because, so that's where we start to really try to get a little bit more specific on the findings. Because now, if we did it before, we go, oh, you got a sloppy back, right? And maybe we fall in the trap of saying, oh, well, you need to do some core strength, or you need to clean up this sloppy back. But it's not her sloppy back. I mean that with all due respect. It's not that she has a sloppy back. It's just that she can't access this part of her workspace. And that's important for me, right? So she was getting that part of the workspace by having a little bit of a compensatory motion. So I clean up this compensation a little bit, and I say, come across again, and I say, oh, well, she's not getting as far. Well, that's important for me to kind of get. It's information for me. Do you guys see what I'm saying there? Good. Continue on, sorry. Little sticky point there, you saw that? Now, this is a real common one. Disregard the fact that she has a really weird elbow. But this movement from here to here should be shoulder rotation, correct? How does she do it? Go ahead again.
Wrist form.
Now she's trying not to, but she has to pronate.
Yeah.
I don't want pronation. Pronation is not occurring at the shoulder. That's not where shoulder rotation should happen. Right? And now she does wrist extension.
Another thing to kind of point out too, so if you kind of clear that up, so people will kind of continue to go on, and then you might see this angle change of their palm. So like they pronate through the elbow, so you go, okay, well they're getting internal rotation
A little pinching right
and a little pinching. We don't care about that. But so what I really care about is I say like almost like you have an X on the end of your on your bicep, and as you go through this range, I want you to make that X look towards me as much as you can. So I want you to steer through your glenohumeral joint. So now they're getting internal rotation of that shoulder.
Do you see how she can't?
And she's
Because what happened now when
rotating
she tried to get that internal rotation? Yeah, now her trunk's moving all over the place again. So that helps us rein in some findings here, because now we say, well, maybe this is a rotational lack of rotation.
Not just this.
Right.
I want to see this.
Okay.
Okay, so then sometimes what we can do is say, okay, so they don't have that. So they have maybe some restriction through here that I might want to go check some the quality of the tissue, but because she can't internally rotate and she gets a mild form of pinching, then I just come through here, check the capsule with internal rotation. And there's where we start to get roadblock, because if we go any more, what you'll start to see is that scap height like that. Does that make sense? So when she tries to access that amount of internal rotation through her car, she's going to call upon the scap. So we got to clear up some more internal rotation and maybe some soft tissue through here. You guys see how that really starts to guide us and pinpoint, if we have an hour with somebody, how we can maximize our time working on the areas that actually need, that are caught, like maybe contributing to what's the pinch point or the limitation of range, pain, things like that. Okay, let's do another one. Thank you.
Yeah.
Who else wanted to do it? You're just dying for this, huh? We're gonna
I'm
pick on
waiting
you
for
so
someone
bad.
that knows what they're doing to lift in my shoulders.
Well, we just made that all up, so.
Yeah.
At any point you guys see something, just say it. Just throw it out. If you guys see something that maybe we don't see. Okay, go ahead.
So, alright.
I'm gonna get to a better angle. I'm gonna just be a student. I'm gonna hang out with you right here. Yep.
Coming up.
Yep. So externally rotate. Start to adduct, freeze right there. Make it tight right fist. Brace through your midsection. Good.
Some extension.
Rotating already.
Losing some elbow extension.
Yep.
Perfect. Alright, keep going.
Yep. Keep going.
Really lumbar extension.
One thing that you guys are seeing too. Go back. Just relax for a second. You guys see how through normal range of motion, body rate, how hard that was? Like he's shaking.
Working hard, yep.
So that's something to like. I want to know, why is he having to work so hard to carry
This
the weight
was
of
a
his
shoulder
tumors?
surgery, set?
Yeah, so I had a slap tear up here. In here. Yeah.
Okay.
How did you tear it up?
So I was wrestling and I fell on the side and it came out.
He lost.
Yeah. It was torn for 10 years before they caught it, so that was what this whole thing's been about.
So you really
Yeah.
Right. Alright, so regroup.
Uh huh. You got this. Breathe in. You radiate. Trap that air. Just a little bit of this. It's not huge, but
So I feel pinching in the front.
here.
What side is that?
Closing or opening? Closing. Okay, so from an assessment standpoint too, by the way, like just so you guys know, like if I felt that pinch, I wouldn't go any further. You know, like I'm already know where I need to go. I'm gonna go start. Where am I gonna go? Capsule. Make sense?
Capsule.
So we know that as soon as he raised up in the
Capsule
flexion,
back.
he started to.
I thought he felt the pinch.
He felt pinching in the anterior form or portion of the shoulder, which means We're talking about so essentially, if we have pinching on one side, we're gonna go to the contralateral aspect of the joint, and then start assessing tissues there. So if he's got pinching here, I'm immediately thinking about what is the deep posterior shoulder doing, and I'm usually gonna start with capsule. So if we go to the same thing, I check internal rotation. Right there, we start to get a lot of like hiking through a scap. You guys see? If we block it, actually I wouldn't do it. I would have him supine and then actually block the scap from hiking just to see what available range of motion he had there. But I can probably tell you, and then maybe if we're kind of happy with it, we're gonna go start assessing those tissues from a soft tissue release standpoint. Okay? But I wouldn't just say, okay, it pinches, just now let's do reps. Isn't that person gonna leave me? Oh shit, my shoulder hurts. I'm never going back to that person. So we know where we need to start at least assessing from that point right there. Okay? Go ahead now and do another version where you kind of bypass the pinch point and carry on with the full circle so you can see the other range. You see how I bypass that little pinch area right there? So he's having a scap protract, retract to try to find and etch out a better circle. Elbows flexing a little bit, shaking,
Extending the lumbar a little bit.
a little lumbar extension. And this is where we're gonna see what kind of quality of internal rotation he has.
Which doesn't look great.
Looks really hard. And look at what, so pause. I'll support you here for a second. So if you were to look at this, you'd say, well, the internal rotation's not so bad. But he's essentially at neutral with his glenohumeral joint.
Oh,
So he's not accessing, see what happened to his scap? You guys see that? So he was trying to create the illusion, which is what people typically do because they want to please you with the performance or the assessment or whatever it is. So they're going to make it look like they're getting internal rotation any way that they can. But when we actually ask what's happening at the glenohumeral joint, we're getting coupling of the scapula, which means really kind of theoretically too, the definition of a joint is two bones that come together and articulate with one another. So if I ask him to actually rotate through, and he can't create rotation at the capsular level, he doesn't own a joint. Does that make sense? So we have to start to create a joint. So this is where like FRC really comes into play because we're gonna really start to see, can we start to create relative motion between one bone relative to another to start to clear up and open up some available capsular workspace. Make sense? Which is the same reason why I just told you guys I had that client that was just in here with a workspace of this. Okay, and the only thing we trained, I was like, I'll show whoever wants to have a picture of it, the before and after, of she, no internal rotation, and she got literally stuck in flexion here. And now after like 1 month of, and she's really wicked at doing her homework too, it's really cool.
Closed chain pain?
A little closed ankle pain, not bad, but she had some closed ankle pain. She was trying to not have surgery. And then she has this now with no closed ankle pain, and her internal rotation is significantly different. By just working, opening up the posterior aspect of the shoulder, we opened up the entire overall workspace of the glenohumeral joint. Does that make sense? And that's how you have a client forever. Because they love it, because now she can do her Tai Chi better and whatever. Let's just go through one more.
In the beginning?
Yeah.
Definitely looks hard as he's coming across.
Mm-hmm. So we're seeing the same things that we saw before, but a lot of scap hiking.
Got more.
Yeah.
So as soon as he calls
Yeah,
upon
but
internal.
it's now a quality issue, right?
Yeah.
Yeah.
Now he's a little bit ratchet.
So he kind of etched out those pinch points. The other thing that he could do is if he felt closing ankle, like let's say I'm doing some treatment and I want him to continue movement of his glenohumeral joint for the health and longevity standpoint, and he's getting pinching at this zone. So maybe he can't find out how to etch out because they have very poor body control. So maybe I have him just start to create a circle out here, and he's just repping out this motion on a daily basis. And then at the same time, I'm working to expand his available workspace, and then he's going to take up the slack by using cars on a daily basis to reinforce the newly acquired range that we created. Make sense?
So initially, if they do find a pinch point, do you try to have them find a way to etch that out first? And then if they're unable to find it, then you just kind of take their limb and kind of guide it what
I
you
find
said.
it kind of depends on the joint. Sometimes I can modify the position of cars too, so gravity's affecting it differently.
Mhm.
Like I have a guy right now that had closed angle pain with hip flexion,
Mhm.
and we cleared up a lot of motion, but he's still like gravity right here and opening on a big joint like the hip
Yeah.
is a lot of load.
Yeah.
But I had him do it from a quadruped position
Mhm.
from here, way less load.
Yeah.
And he was able to at least so because all I cared about was just at least he's moving his hip joint,
Yeah. Absolutely.
and I'm clearing out other stuff up in the meantime. So I modified position at that point.
Okay.
Which that in your guys' webinar too. They're gonna go right now. We're in what's called CARS level 1, which is conscious blocking. So I'm just saying, hey, I noticed that your elbow bent a little bit, your scap hike. Next time you go through it, can you try to avoid your elbow from bending and your scap hiking? So now they put that in their head of consciously blocking out those compensations. Then we have CARS level 2, which is now, and I don't want to. This is all in your guys' webinar, but that's where we create blocks to eliminate the possibility for our partner to cheat. And there's a reason why you would do it. You don't, from assessment in daily joint health routine, we're at level 1 always. Just have people do level 1s. It'll explain level 2s in there. And then level 3s are like, if you want to see like some really, really, really hard articular training, you go into CARS level 3, which is like we give any external props, tennis balls, put a block between his knees, have him stab a dowel down on the floor to bump up your radiation internal tension loads. So that way he's having to really induce a higher amount of internal contraction to increase the effort and the load going into the movement. So it makes you feel like you want to throw up after. It's super hard, yeah.
When you like pin yourself up against a rig and do it, is that a 2 or a 3?
2. Yeah.
Say if you booked an hour-and-a-half session with a new client, it's assessment and treatment session.
Uh-huh.
You come in, you start assessing, they have pain throughout everything that you're doing, you check the rear capsule, still has pain. At what point would you end the session and say, there's nothing I could do, to what point would you still, like, treating throughout pain-free? Or like just ending
I had
the session
someone
and
come
saying,
in that had a pretty fresh supraspinatus tear. And I still had him doing CARS, and I still did soft tissue work. And sometimes, obviously I'm a massage therapist too, so anything that you do right now that takes someone out of pain and makes them comfortable is gonna make someone feel better. So you'd still do that. Like sometimes just having someone lay down on a table for an hour, like that helps bring them back into a little bit more of a parasympathetic state, which maybe is really helpful for that person. So, but like maybe his CARS are probably like this, like very, very low effort, right? And you know what I mean? So like I think you can always do something like Mike said. He had that guy that had what? Do you know what degree of tear that was on, or sprain that was on your Instagram post, Mike?
2++.
And he was doing soft tissue intervention right there. So I think there's always something that we can do, right? So maybe I'm just not going to put him through. Maybe a lot of it is I'm just directing more a longer duration internal or external load with my hand and doing less movement-based treatment, right? Because usually everyone wants to have something like rubbed on. Okay, cool. Anyone else did you have something you wanted to go through? You wrote?
Yeah, I'm just gonna go through why, sort of tie this all up for you guys. Is everybody good with CARS assessment? You guys are gonna see in the webinar that you have, we go through the CARS assessment in a little bit more detail. You're also gonna see that the CARS in the webinar are going to look slightly different than the CARS you just did. The reason is because we changed them. So we used to not do external rotation adduction. So we used to just do pure flexion and then rotation.
That's how I learned it.
Yeah, well, that was sort of an oversight on our part for a long period of time, in that you guys don't take a picture of that, by the way. I'll kill you.